Well, good evening, everyone. It's 7:30. If someone could just throw in the chat whether or not they can hear me. Euston Tap, fantastic. Welcome along, guys. Good to see lots of familiar faces and still a few people arriving, so we'll just give them a chance to settle in. Welcome along. Tonight we'll be talking about sepsis. Those of you that are new to this webinar, then thanks for coming. We are kind of coming towards the end of this current series, so there's lots of material online to catch up on if this is something that interests you. We are STC Training Solutions. We're a pre-hospital care training provider based in Aylesbury, and we specialise in FREC 3 and FREC 4 delivery at the moment, with FREC 5 coming in the spring. So we put this series of webinars together for students of ours that we're going through. And we thought actually it'd be quite useful for those of you that are doing your FREC elsewhere. And of course, we would of course love to see you face to face on one of our courses in the future. So there's some details coming up on upcoming courses if this is something you're looking at doing. So my name's Dennis. I'm a paramedic practitioner by trade. Used to work for a couple of the ambulance services full time, now bank, but work full time in a GP surgery. So I've seen a fair kind of different, a few sides of medicine up to date. So and sepsis, of course, is one of the big subjects. Doesn't matter where you work in healthcare, you'll come across sepsis in some regard, or at least you'll be screening for sepsis in lots of different areas. So it is an important subject. Let's say this evening is going to be about an hour long, just talking about some of the areas of sepsis that you'll need to know. This is aimed at people going through FREC 4 predominantly. It is a requirement, pre-course requirement, to read around the subject of sepsis before you start your FREC 4 course. And this webinar, of course, will help point you in the right direction for things that you need to be reading around, or a bit of CPD for you. And of course, it counts towards your 118-hour requirement between doing a FREC 3 and FREC 4. And of course, hopefully those of you that have done FREC 4 or further than that will find this a useful refresher this evening. A couple of people still coming in with the looks of things, so you haven't missed anything yet. Welcome along. If you're new to us, thanks for coming, and of course really nice to see the faithful group that are usually there. So very nice to see you. We see you face to face soon, which is good. Matt, great to see you. Euston Tap sounds like a pub, I hope. Oh yes, good quality beer, lovely. Brian, oh fantastic. Okay, I get the joke. Fantastic. Brian came down to see us last week to do his ILS, and we had a bit of a running joke, didn't we, of some places in America you might like to visit. I don't particularly want to visit Tamponade or Thrombus. Least of all gonorrhea in Ohio. Where was it? Is that the one? So welcome. Okay, so it's just gone 7:30. We'll get going, shall we? Of course, these are recorded, so if you know of anyone that would be interested in these, just ping them a message and they'll be up on our Facebook and website for these soon. I should mention last week's webinar hasn't appeared on our website yet. That's for one or two reasons. One, it needs a bit of editing because of the PowerPoint problem, and two, we're just updating our website at the moment, so we couldn't get it on there in time. So that update is going to be done over the next couple of days. You'll see last week's and this week's probably will arrive together when we get that done. So as I say, we are a FREC training provider. We do have courses coming up. We have FREC 3s and FREC 4s galore at the moment. So we have both weekday and weekend options available. So the weekend options are split over 3 weeks. Next FREC 3 weekend starts on the 20th of November. There's only a couple of spaces on that now. Then we have a weekday course starting on the 15th of November, 1 space left on that. That's a Monday to Friday course. Next FREC 4s, we've got a weekend course starting on the 8th of January, which is bizarrely nearly full already. And we have a FREC 4 Monday to Friday starting on the 22nd of November, which again is getting close to full now. I've just missed an ILS, that was last Sunday, so do come and see us on the 12th of December if you need your annual ILS refresher. And we've just added an extra SARM date in because all our SARM courses were full, so nobody could get on. So we've got an extra SARM date on the 18th and 19th of December, so just before Christmas, weekend before Christmas. If you want to get your SARM done, it's only 150 quid, come and join us, and it's me teaching it, so we'll have great fun, I'm sure. That's enough of the plug anyway. We'll get on with tonight's sessions, if I can get PowerPoint to work without having a hissy fit again. like it did last week. Here we go. So the series so far, we've talked about CPD requirements. As I say, we are going to update that because some of the changes that have come in over the summer. Anatomy and physiology we've done to death, haven't we? Along with common pathophysiology, they're all recorded and up on our website if you'd like to have a look at those. Maternity care was a couple of weeks ago. Then we had patient assessment, paediatric assessment. That was last week. This week, we're going to talk about sepsis. Next week, we're going to talk about oxygen and Entonox guidelines. That's only a relatively short one, but that's just a quick recap, or if it's brand new to people. We're going to talk about ECG Basics over 2 sessions. That's aimed at the level you need to know it at for FREC 4, plus a couple of other little helpful pointers. So we're not going into huge detail about that. There is a series on our website of much more in-depth stuff, if that was something you were interested in. Intermediate life support, we're going to have a session on that in a few weeks' time. That's a theory session, doesn't replace your need as a FREC 4 or FREC 5 to have an annual face-to-face. And then by popular demand, we've added in the SARM medication refresher. Those of you that have done your SARM course, or if you know of anyone that has, and wants to just recap, there have been some quite interesting changes, most importantly, the management of anaphylaxis pre-hospitally. So we'll go over any updates in the last year, and plus we'll just have a recap around how the drugs work, what we use them for, etc., etc. So hopefully you'll join us for a few more of those sessions, and then we're going into another series which is going to be a lot more practical, but we are taking suggestions for what you would like to see. So tonight, pathophysiology of sepsis, recognition features, both adult and children. We're going to look at News 2 and POPs. And we are going to talk about adult management, paediatric management, and then of course there'll be the usual Q&A session at the end. So we want this session to be interactive. Do grab your smartphones. There will be another competition this evening. Brian was a winner a couple of weeks ago, got 10% off his ILS course. You'll have the chance to take 10% off any course of your choosing, and I will honour that against the FREC 5 as and when it gets going. So if you win tonight's quiz, then as I say, you'll have a 10% off ticket, any course you want. We will keep an eye on the chat. Anything you want to ask, just chuck it in the chat and we'll address it as we go, or there'll be a Q&A at the end, as I say. Feel free to tweet us, email us, or WhatsApp us at any point, including after the event tonight. Reading as usual is the 2 ambulance care practice and ambulance care essentials, and of course JL Calc for pretty much anything to do with patient management, although the 2019 guidelines are relatively out of date now, so buy the app rather than the book. Charlotte's on her way home. She was on an ambulance today and finished late, as is standard, so she'll be home shortly. So let's get into Mentimeter then. So grab your smartphones, go to menti.com and pop in, whoops, bear with me. Mentimeter is having a moment. Bear with, folks. Let me just fix it. It wouldn't be a live webinar without some problems, would it? Okay. There we go. Now, hopefully you can all see the question on the screen. So go to menti.com, put in the code 89833818. So that's 89833818, and ask the question for you, what is sepsis? You can have up to 3 answers. Let's see what people think sepsis is. A mystery, I like that. Leaky vessels. Spread infection causes death. It certainly does. Infection in the blood. Spread infection. Great. Systemic infection. Good. Big sick. I like it. Good. Good. Leaky vessels causing death. Absolutely. Needs hospital. I agree. Build up of toxins. Inflammatory response. Good. All of this stuff is good answers. Well done. Deterioration, fab. Metabolic, yeah, can be. Okay, physiological changes, good. We'll go into what those are. Yes, it does happen at cellular level, critically ill. Okay, lovely. So some really good answers coming out there, folks. Absolutely. We've obviously got a fairly good idea between us of what sepsis actually is. So I thought this sums it up quite simply. So sepsis is an infection, and it's an infection that causes a kind of hyperactive response from the immune system, if you want to think of it that way. So Whereas a lot of the features of sepsis are normal physiological findings in somebody that has any infection. Now I think it's important to just point out that any infection can cause sepsis, and anything is possible. So all the way from the common stuff like untreated chest infections that become kind of pneumonia, to urine infections in the elderly, to meningitis, of course, which is a very, very good cause of sepsis. They can all cause this scenario. So what this scenario is where, if you just imagine when you get infection into your body, the immune response is to send white cells. So the macrophages, the cells that are going to eat up all this kind of pathogen that's come into the body. It doesn't matter how that gets in, whether that's something you breathe in, whether it's something that punctures the skin, or whether it's something that you eat, etc. So that pathogen, that thing that shouldn't be in the body, is going to be attacked by white cells of the immune system. Now, the white cells, as I say, are generally thought to be the largest cells in the bloodstream, and of course, they don't pass through the walls of the bloodstream particularly well. And obviously, they've got to get out of the bloodstream to get into the space where this infection is to start fighting it, right? So, of course, what happens is the blood vessels in the area, in that localized area, they start to leak, they start to dilate, they start to pull apart, the cells spread apart, and those white blood cells are allowed to escape. But of course, as they're relatively large in comparison to other cells in there, they do allow other cells to kind of leak out, and that's what we get the kind of the cardinals of infection from. Namely, you're going to have some swelling, you're going to have some erythema, i.e. reddening of the area, and you're going to have some heat, you're going to have some pain and kind of reduction in movement. And that's all that swelling and that heat is just all those blood products pooling in the area, with the aim of getting those large white cells to the area to start eating up these pathogens and to trigger the kind of secondary responses of the immune system. Now that's fine, that's what's supposed to happen. And of course, going on in the background, you've got the body turning up the thermostat, the hypothalamus starts sending signals to turn up the thermostat, so you start to run a temperature. The reason being, the body can tolerate generally a larger range of temperature than a lot of these pathogens can. A lot of these bacteria will die to relatively high temperatures, whereas the body will carry on, relatively as normal. We're talking kind of 38, 39 degrees, of course. Sometimes is enough to slow the spread of bacteria. So that's going on in the background. So all of these things are normal. Of course, if you start to dilate your blood vessels, you start to relatively drop your blood pressure. So of course, the body's response to that is to increase heart rate. And of course, your metabolism's increasing. You're trying to fight infection. So your body's working harder, your respiratory rate's going to go up too. So these are normal findings. So when you have a patient with an infection, you expect to see a temperature, you expect to see raised heart rate, you expect to see raised respiratory rate. You don't expect to see lower blood pressures or lower levels of consciousness in a patient that is coping. So of course, we're now starting to talk about, well, how are we going to tell normal infection from systemic problems that are causing sepsis? Well, what actually is sepsis? So if you think you're all right with a kind of systemic response that makes the patient really unwell. So what's going on? Well, what you have to imagine is in this stage here, where you get this source of infection, something happens where a significant amount of bacteria, it's saying bacteria here, but this could be any pathogen, any source of infection, they start to kind of accumulate within the bloodstream. So that happens for a variety of reasons, and to a greater or lesser extent, it's always going to happen. You're always going to get the odd pathogen that's going to sneak through by osmosis. They're going to go from areas of high concentration to areas of low concentration, down that concentration gradient. And if those blood vessels in that area are leaky enough to let the white cells out, they're probably leaky enough to let the pathogens in. So to a certain extent, we're always going to get that. But what happens in sepsis is that starts to happen a little bit too quickly, and that starts to overwhelm the immune system. And the long and short is, if you imagine now that you've got a significant number of pathogens within the circulating blood volume, and what are they doing? They're encouraging the white blood cells to eat them. They're encouraging the white blood cells to release all the chemical messenger signals that they normally release. And in doing so, that causes the blood vessels all over the place to start leaking. Now, can you see that's when we get a problem? So if this is happening, let's say this is a chest infection here, you've inhaled some COVID. That's the good one at the moment, isn't it? So you've inhaled some COVID, and in the local area, the capillaries around those alveoli where you've inhaled it have started to dilate, and we've started to allow some blood products in, some white blood cells to start eating that COVID and starting presenting it and asking for backup. If some of that COVID then spreads into the bloodstream, of course, that in significant numbers, of course, we're going to start then that immune response happening all over the body. And can you see then? So if we've got leaky blood vessels all over the place, what's going to happen to our available circulating volume? It's going to very, very quickly deplete. And of course, your blood pressure then is going to start to drop, because no amount of increasing heart rate and arterial tone, etc., is going to be able to kind of counteract that. So this is the term sepsis. Sepsis is effectively, it's a combination of things, but sepsis basically is when that infection spreads into the blood and it overwhelms the immune system to the point where your circulating volume decreases. And of course, that then starts to cause organ failure and ultimately death. So that is sepsis, and that is septic shock. Once the organs start to become so poorly perfused that they start to fail. So that is septic shock. It's a type of distributive shock, if you remember the different types of shock that are available, from hypovolemic, which is functionally bleeding, effectively damage to blood vessels internally or externally, to distributive shock, which is where the blood volume is still in the body, but it's just not quite where it's supposed to be because of things like sepsis and anaphylaxis. You've got cardiogenic, neurogenic, and obstructive are the other types that we less commonly encounter. So somebody said, absolutely, you can get low temperatures. And actually, there's this term called cold sepsis. It's far more rare than hot sepsis, if you like, classic sepsis. But it is possible for patients to, when their immune systems become completely overwhelmed, for their temperature to start decreasing. That's generally a sign of multi-organ failure. It's generally a sign that the brainstem isn't getting perfused enough as well, that the hypothalamus is starting to go off. But actually, there's a huge element of we don't really know why some people get cold sepsis. But it is rare. I've not seen any genuine cases of cold sepsis. I've seen patients who I thought have sepsis and have a low temperature, but that's been for other reasons. So it is a rare one out there, but don't discount sepsis just because a patient has a normal or a low temperature, as we'll talk about very, very shortly. But that's effectively it. That's what sepsis is. So an overwhelming immune system response, which starts to result in organ failure. And that's septic shock. So here we go. Let's just summarize it. So the immune system is activated by the arrival of the pathogen, as we've said. This is normally through white cells, the larger white cells, the macrophages coming along and eating them. Again, that pathogen can spread into the bloodstream. If it does so in significant quantities, we get septicemia, effectively septic blood, or what used to be called systemic inflammatory response syndrome, SIRS, which was like the precursor to sepsis. So sometimes what can happen is the immune system starts to attack the own body. If you think about a very overwhelmed army, and effectively you've got enemy everywhere, and it's just you with your machine gun, and basically you just start spinning around on the spot, firing and firing and firing. That's kind of what the immune system does when it's so overwhelmed with these pathogens. So it starts to attack, a bit of friendly fire going on within the bloodstream, which doesn't help the situation if it's leaking all over the place. Now, the end result there is the organ dysfunction. Once you get that dysfunction, that is technically sepsis, but it's everything that leads up to it that makes it sepsis. And then once your blood pressure crashes, once you start to become, centrally poorly perfused, then we term that septic shock, which is a type of distributive shock, as I've said. So we're going to go back to our Mentimeter. If I can find it. There we go. So next question, please. So grab your smartphones again, go back to menti.com, 8983-3818, and answer the question: for which scoring system is used to detect sepsis in adults? CRB 65, Wells, News 2, or GCS? Which of the following scoring systems do we use, excuse me, to detect sepsis in adults? All vote now. Well, let's kind of at least, there you go, we're up to half already. We're a bit more, let's see where we're all going. Okay, clearly everyone knows the answer to that. So they paid attention in the patient assessment webinar last week. So you're absolutely right. So News 2 is the preferred method currently in the UK for pre-hospital and in hospital for identifying sepsis. Okay, you'll become very familiar with this as you work out there. I'm sure those of you that aren't already. Things you need for a News score: you need the respiratory rate, you need the patient's saturations, you need to know whether they're on air or oxygen. Clearly, you need to know their blood pressure. Only the systolic's important at this stage. You need to know their pulse their level of consciousness, and you also need to know their temperature. They're the observations you need for a News 2 score. And of course, we should be, if we're in community settings where we're actually monitoring patients, then of course we want to be taking serial observations to look for decline, deterioration. But of course, a lot of us aren't going to be in that luxury. We're not going to be able to decide. It's going to be a case of we assess the patient, they hit some markers, and we send them in. So respiratory rate 12 to 20, which is normal adult range, of course. Anything lower than that, anything higher than that is going to score you either 1, 2, or 3, depending on which box you land in. I'll come back to the oxygen scale. If you give the patient oxygen, you automatically score them an extra 2. Systolic blood pressure, again, we're really only interested in lowering blood pressure. There is a new version of News due, I'm told, I've heard on the grapevine, because it's all been appreciated that 219 is a crazily high blood pressure. And actually, if we're using News for scoring more than just sepsis, actually a score of 0 is not really appropriate there for 219. Anything over 180 requires ambulatory care generally. So I think the latest version of News is going to just acknowledge that. But generally, when we're talking sepsis, we're only really interested in reducing blood pressures. Absolutely, News 3, who knows? And then we have the pulse. Again, anything below 51 is considered to be a problem. Anything above 90 is considered to be a problem. When we look at this, because obviously we know that 60 to 100 is the textbook normal for average adult blood pressure, heart rate. Of course, we're using this in the context of sepsis. There has to be some clinical judgment. Clearly, you've got Mo Farah in front of you. His normal resting heart rate is going to be in the 40s anyway, if not slightly lower. So clearly that's not going to be a problem. Whereas little old Nana sitting in front of you at 50 is probably a bit more of an issue, isn't it? So using a bit of clinical judgment. Level of consciousness, anything other than alerts, basically. And temperature, again, cold sepsis is acknowledged here, isn't it? So when your body temperature starts to decrease because of multi-organ failure, clearly that's a problem. But we're much more likely to see a higher temperature. And of course, we know that adults generally don't take temperature. It's hard for an adult to get a temperature over 40. That's generally a sign that they are pretty unwell, although that's not acknowledged in News. It's just something to be aware of. Temperatures over 40 in adults are usually quite significant. Irish CPG mentioned as well the glucose over 7.7. Absolutely, yes. So when we first heard about this thing called COVID, some of our guidance in the ambulance service was to check blood glucose in everyone suspected of COVID, because actually early stages seeing raised blood glucose in non-diabetics can be indicative of problematic infections, i.e. going down the road of sepsis. That was dropped locally. I don't know the reasons why we no longer kind of go after blood glucose quite as frequently as we were at the beginning of COVID. But yes, it was proving to be a relatively useful marker. I can certainly say from my own experience, those with the higher glucose levels did tend to be the sicker patients. So I still tend to do them when I'm a little bit concerned about people. But good. So it's interesting the Irish guidelines still advocate it. So how do we spot sepsis in adults? I mean, this is the oh, sorry, I forgot to mention the oxygen saturations there, didn't I? So there's 2 SAT scales, and I think this has always caused confusion in the past. It was rather oversimply thought of as being scale 1 was for normal healthy adults, and scale 2 was for those with COPD. It's not quite that straightforward, although you're not a million miles off if you do that. Scale 2 is actually for those that are at risk of hypercapnic respiratory failure, which is a very specific kind of set of criteria that patients is generally only going to apply to patients with COPD, hence why it was oversimplified. But patients with COPD that generally run at very low oxygen levels anyway are much more likely to go into respiratory failure if given too much oxygen. So we tolerate those patients having lower saturations before we do anything about it. So it's not all COPD patients, it's only COPD patients that generally run at a low level of oxygen anyway. If you don't know, or they don't have COPD, then we use scale 1 because it's still better to overtreat than undertreat in these situations. Now, of course, a lot of you are going to be thinking in your head, well, JL-Calc says give the same amount of oxygen to somebody with COPD as you would to somebody without, which is absolutely right. The Sepsis Trust and British Thoracic Society disagree with that, but of course, this is the joy of medicine. Not everybody agrees on all the guidance. We tend to follow JL-Calc, and JL-Calc say we give oxygen regardless of their saturations if they're septic. Okay, fab. So Matt has put a bit up there, but there we go. Fine, fair enough. is raised outside the narrative. Fair enough. Okay, there you go. That explains it. I don't know why we don't use blood glucose quite as much as we were at the beginning. So how are we recognising sepsis in adults? Well, this is what the general public are told, isn't it? I think this is about the most naff mnemonic anyone's ever come up with. So how to spot sepsis: slurred speech or confusion, extreme shivering or muscle pain, passing no urine in a day, severe breathlessness, it feels like you're going to die, skin mottled or discoloured. I mean, I'm sorry, that is the most pointless mnemonic, but you will see that out on the side of ambulances and on the wall in our GP surgery. We've got this plastered all over the place. Not the most helpful. Nobody can remember it. So the Sepsis Trust do produce some very, very good guidance for healthcare professionals there, you'll be relieved to know. So sepsis recognition in adults, this is available as an A4 PDF from the Sepsis Trust website. It's completely free, so do go down and download it. It normally forms the basis for most of the ambulance service guidelines anyway. I mean, London and South Central tend to use this pretty much word for word in their own format. But we're looking at, for sepsis, we've got to calculate a news score. That's the starting point, isn't it, for adult sepsis? So if the patient looks unwell or their news 2 is 5 or more, okay, so if we've calculated a news, it's more than 5 or more, then we're going to start the sepsis criteria here. So there's some ideas of things that make you more risk of having sepsis over 75 years of age, because your immune system's a bit slower to respond. Impaired immunity, diabetes, steroids, and chemotherapy is a classic one. If you've got a patient who's unwell with an infection after chemo, it's neutropenic sepsis until proven otherwise. Just don't even think about news scores and things like that with recent chemo. Chemo in the last 8 weeks. If they're unwell, if they've got an infection, they are neutropenic. Take them to hospital. Okay. Recent trauma, surgery, those types of things, of course, and indwelling lines, intravenous drug users, those types of things, they're all going to be higher risk. They just have that lower threshold for thinking that they're unwell. It's got to have an infection. If there's no infection, it's not sepsis. I'm not denying that they won't be unwell if their news is like 14. They are unwell, but if they don't have an infection, it isn't sepsis. You need to think about what else it could be. And my go-to when I teach this in FREC 3 and FREC 4, if you've got someone with deranged observations, they've got a high news score, it's either sepsis or it's blood loss. It's a type of shock, isn't it? Until proven otherwise. So if you're not thinking it's sepsis, try and figure out, are they bleeding? Or is it, massive cardiogenic shock because they're having a massive MR? You just don't know. But if it's not infection, it's not sepsis. Then we're going to screen for things called red flags. And I want you to use the term, get used to using the term red flag sepsis when you pass your pre-alerts to hospital. If you're taking these patients in, you need to use the correct terminology. This is query red flag sepsis. Okay, tell them why, obviously, and whatever format, normally ATMIS. So any red flag present with a patient with a news score of over 5 or looking unwell is going to equal red flag sepsis. This obviously makes a lot more sense when you have it in one single sheet of A4, which you can, as I say, get from the Sepsis Trust website. Objective evidence of new or altered mental states, so confusion, etc., is going to trigger red flag sepsis. Again, that's as we expected from news, because that gets you a 3. Systolic blood pressure less than 90 in an adult or more than 40 drop from normal. So if you've got a patient that's normally hypertensive at 140, 150, and they're down at 100 or 95, that's a red flag. Heart rate over 130, respirate over 25. A lot of this follows the news 2 scoring, doesn't it? Needing oxygen to keep them over 92. I mean, great if their SATs are low anyway. And then non-blanching rash clearly is signs of meninginism, isn't it, or meningococcal septicemia. We need to be a little bit wary of that. But non-blanching rash can occur in any form of sepsis in the late stages. Someone's just asked, do we do point of care testing lactate? It's being trialled in various forms. We are trialling some in primary care as well. So I don't suppose it'll be long before we're measuring lactate, but at the moment that's not something that's routinely measured by ambulance trusts. Some of the specialist paramedics out there do have kits on trial, as I say. In primary care, it's one of the things that are being trialled. Recent chemotherapy, there you go. Immediately go to A&E. Don't pass go. Don't collect £200, and not pass urine in the last 18 hours is significant, isn't it? Most of us work on ambulances and we go 12 hours without passing urine, but 18 hours is pushing it. and less than 0.5 ml per kilo per hour if catheterized. Amber flag sepsis basically just means they may not need to go to A&E right now, but they do need to be assessed by a suitable clinician within 24 hours. Okay, so that's normally GP referral if it's during the day, and get them to see them. Middle of the night, it might still mean a trip to A&E, but you might be able to get away with urgent treatment centres rather than the actual A&E departments, but that depends on your local pathways. I say that without laughing, based on where I normally work. So urgent treatment centres don't take anything. So amber flags that you're looking at there, relatives concerned about mental state. I mean, that's pretty subjective, isn't it? Acute deterioration in functional ability. So that's the term of being off their legs. You know, little old Nana with a UTI and she's not walking quite so well is going to be amber flag sepsis until proven otherwise. If they're immunosuppressed because of DMARDs, medication for rheumatoid arthritis and Crohn's, those types of things, they're all going to be high risk. Trauma, surgery or procedure within the last 8 weeks, respiratory rate in that range, you know, you can read those. Temperature less than 36. So the early signs of sepsis actually do start with a little bit of a dip in temperature sometimes. Or clinical signs of wound infection, that's the cellulitis as well, can be branched into that. So we go back to Menti then. Let's have a little look at the next question, which is which scoring system is used to detect sepsis in children? Now, I know this is open to debate. That's why I haven't put the 2 options up there. But which one do we use to assess for sepsis in children? In hospital, use a different set of scoring system than we do out of hospital traditionally. We have one that is much more user friendly for the pre-hospital environment. Which one is it? Again, I'll let kind of half of you get on there. So A, B, C, or D. POPs, ABCD2, News 2, or FAST. Which one do we use to detect sepsis in kids? Fab. Good. Let's see where we're all going for. Most people going for POPs, which of course is correct. So News 2 is adults only. POPs is for children. Pediatric Observation Priority Score. The other one that can be used is PEWS, and it's actually mentioned by the Sepsis Trust in their guidance. It says look at their PEWS score, Pediatric Early Warning Score. We don't use that pre-hospitally. We have a look at POPs generally. So 85% of you getting that right. So it's built into our ePCRs, actually, the POPs scoring. It's very useful. Here it is. Again, you're going to grade them based on their score. With News, anything over 5 and above is concerning. In kids, it's pretty much the same, but slightly lower thresholds with children. 0 to 1, they're probably okay. 2 to 3, be a little bit concerned, kind of thinking amber flag. 4 to 7 is red flag, and 8+ is definitely kind of, you know, we need to get them in. They're possibly peri-arrest. So POPs is a little bit more complicated than News and PEWS. So we've got a few things. As I said to you, any of you that came along for the paediatric assessment last week, I'm sorry for the repetition, but generally we're looking at we do all of these boxes at the top. So saturations, breathing, alert, voice responsive, pain responsive, unresponsive, your gut feeling, which is great. I like having this subjective element because some kids you walk in, they look rubbish, and you're very worried about it. And then but actually you just can't put your finger on why. So it's nice to have that child looks unwell, subjective look. And then you've got other things that make them high risk. So let's look. Any child with saturations below 95 clearly is going to start scoring something, okay? Breathing, if they've got stridor, if they've got grunt, if they've got wheeze, if they've got recession, we're going to score them. Now, the good thing about POPs is we can accumulate, okay? So let's just say a child had stridor and severe recession. That would score 4. We wouldn't just use one or the other. So that would actually score them a 4. Similarly, if we had a wheeze and some moderate recession, that would score you 2. Obviously, if it was just the recession with no wheeze, it would score you 1. Hopefully that makes sense. AVPU, again, there you go. We're going to score them on that. And unresponsive clearly is going to be a 2 as well. That doesn't say it, whether you feel that they're unwell. And then, of course, other. And again, you pick from these. If they had 2 of these, you would accumulate the score. So let's, for example, oncology patient that was also premature, they would score 3. Okay, a patient on long-term steroids and diabetic would score 2. So this is why it's a good scoring system. Okay, 8+ is seriously unwell. All right, so and local guidelines will dictate. Absolutely. So Anthony's just saying he uses PEWS in hospital. Yes, most of them do. I like POPs. I think it's got that subjective element, and actually it's a bit more thorough. And it's generally right. It's generally, if they've got a high POP score, they're not well. It does help you with those kind of deciding whether or not to send them in type decisions if you're in that situation. And absolutely, the paediatric assessment triangle and tickles and all that stuff we talked about last week is obviously to be used as well. Then we're going to select one of the 4 rows here, depending on their age. This is their age down the side. So 0 to 1, 1 to 2, 2 to 5, or 5 to 12. So let's say we had a 7-year-old. We're going to use the bottom boxes. So we're going to look at their pulse. If their pulse is between 80 and 120, great. If it's slow or if it's fast, then obviously we're going to score appropriately. Respiratory rate, just the same as news, up or down, and temperature up or down as well. Okay, so and in the end, you will end up with a score. As I say, be very afraid if it's 8 or more. Okay. Good. Sepsis recognition for kids. This is what's plastered on the side of ambulances as well, and in GP waiting rooms and over the internet. This is a bit more useful than the public version of the adult one with the NAF mnemonic. This is a bit more useful, isn't it? Any child who's breathing very fast, has a fit or convulsion. I mean, most people don't need to be told to call an ambulance in that situation. Then it looks mottled. Mottled is that kind of corned beef look to your skin when you're really cold, but in a kid that could be a sign of circulatory failure. Bluish, obviously the cyanosis, the pale, again, circulatory failure. Has a rash that doesn't fade when you press it. Again, I don't know many parents that would need to be convinced to call an ambulance in that situation. Very lethargic, difficult to wake. I mean, children are teenagers, and also I say teenagers are children, and I think most of them are lethargic and difficult to wake, but in context, and feels abnormally cold to touch. Children should be warm, they should have good circulation. Any child under 5 who's not feeding, is vomiting repeatedly, or hasn't had a wee or a wet nappy for 12 hours, again, do you really need much convincing to go and seek help? Ask the question, could it be sepsis? And that's all we ask of you as well as healthcare providers, is if you're going into someone with a temperature, just ask, if it looks like infection, could it be sepsis? All right. For us though, pre-hospital care guidance for spotting sepsis, where it says PEWs, just replace it with POPs. If there is parental concern, i.e. there will be, if you've been called, clearly there is parental concern, the child hasn't called for themselves. If their POPs is high, is over kind of 3 or 4, really, we're going to take some concern. Work through this list, okay. Impaired immunity, again, for the same reasons, indwelling lines and recent trauma, etc., is obviously going to make them higher risk, but you're not going to not work through it just because they don't have one of those things. Is there an infection? Again, just because they're a child, just because there's no infection, if there's no infection, it can't be sepsis, but they can still be unwell. POPs is very specific. If POPs picks up, the very high score, just because there's no infection doesn't mean they're not unwell, okay? But they do have to have an infection for it to be sepsis. And here we go. So a red flag sepsis in kids does depend a little bit on age. So we've got 5 to 11 here, and of course, we have a red flag, objective evidence of neural to mental state. Again, that's the confusion. Doesn't wait when roused, won't stay awake, looks very unwell to a healthcare professional. Nice to have that subjective nature again. Severe tachycardia, which is defined by the chart at the bottom, or severe tachypnea. Bradycardia, any child that's bradycardic is unwell. There's something not right. They shouldn't be bradycardic. They need oxygen. I mean, I think 90 is low. If they're at 94, I'm a little bit concerned about a child, let alone at 90. Non-blushing rash, the mottling, the ashen, which is going grey, cyanotic, which is going blue, temperature less than 36, because cold sepsis seems to be more prevalent in kids. Amber flags, there we go. We've got those, again, you can all read them. This is all freely available to download from the Sepsis Trust website. Again, you're always going to have parental concern. So, but the fact that the ambulance has been called, you've already got amber flag sepsis. So again, the moderate figures are given there. I think again the saturations at 92 is a little low for me. I think less than normal is of concern. And clearly you're not going to leave them at home because you can't leave them at home with oxygen. So delayed capillary refill time. Red flag sepsis, again in under 5s, just a little bit more generic. So doesn't wait when roused, won't stay awake, looks very unwell, weak, high-pitched, continuous cry. The severe tachypnea, tachycardia that we defined below, again, they've got new tables there. Non-blanching rashes again, bradycardia again, temperature under 36 again. If they're under 38 months, under 3 months, a temperature of over 38, because again, in those stages, the body can't regulate its temperature, so we're definitely at risk of some underlying illness, or underlying damage occurring there. And SAS less than 90 clearly is a massive warning flag. Again, I don't know where these 90 and 92% figures come from in kids. I think That's a very low figure to be aiming for. Again, amber flag, there we go. It's the same type of stuff, just a little bit more generic in the under fives because you can't communicate with them. And the moderate figures for tachypnea and tachycardia are given below. So that brings us back. So what's Matt said? So I have a teenager that meets the description on a daily basis. She can sleep for 18 hours regularly. Absolutely, absolutely. I think this is when we talk about in classroom sessions, we talk about signs and symptoms of meningitis. At least 75% of them are also signs and symptoms of being a teenager. So it is very, very difficult. And then of course add alcohol into the mix once they turn 18. It's, you know, you can be forgiven for thinking they will have meningitis. So, okay. I want you to answer again. You got up to 3 answers here. So menti.com, 89833818 again. Have a look at what the current recommended pre-hospital treatment of sepsis is. You've got up to 3 answers. You have to use them all. Throw in the screen there. What do we do for patients? Antibiotics, IV. Okay. Diesel, yeah. Keep them warm. Not so much. If they're hot, we want to try and help cool them a little bit if we can. Reduce the temperature. Good. Somebody's put monitor. Definitely oxygen. Everyone's saying oxygen. Good. Okay. Reduce the temperature. Antibiotics. So again, I'm gonna challenge antibiotics. Not pre-hospital at the moment. Only in a couple of very extreme circumstances do we get antibiotics pre-hospitally. So IV fluids, good, 100% oxygen, broad spectrum antibiotic, reduce the temperature. So pre-hospital treatment, less so of the antibiotics at the moment. There is something called the Sepsis 6, which you can all look into, I'm sure, which is what they do in hospital, 3 out, 3 in. In pre-hospitally, we don't do much of the out. We just do the in, which would be fluids and oxygen. And yes, antibiotics, early antibiotics are indicated, but generally most trusts don't carry them. They write ones anyway. So good. Diesel, I like that. But, you know, rapid transport to hospital is what you mean by diesel. And absolutely, I agree with that. So fluid challenge, yeah, for the paramedics, absolutely. We're indicated for fluids. But good, most people staying oxygen. I like that. So, oops, there we go. Pre-hospital sepsis bundle. So one for adults, one for kids. They're very, very similar. Oxygen, so this is what the Sepsis Trust say. Oxygen to maintain saturations of over 94% or 88% in COPD. What JL Calcs say is another thing. Okay, and I'm going to ask you what JL Calcs say very, very shortly, so don't put it in the chat. Measure the lactate if available. Okay, that's being trialled at the moment. That's not routine for ambulance services to be doing that lactate pre-hospitally. 250 ml boluses of fluids. Okay, sodium chloride standard fluid can be given by paramedics if their blood pressure is okay. If the blood pressure is high, we don't give fluid, and obviously if the signs of heart failure, etc., we don't give fluid either. Maximum of 2 litres. Okay. So if they're hypertensive, sorry, we don't give any. Or if the lactate's more than 2, but again, we're not measuring the lactate out of hospital. So pre-alert to the nearest receiving A&E department, hand over the presence of red flag sepsis and use that term. And then there's the key. NICE recommends the rapid transfer to hospital over giving all the other stuff. I use the example of what if you're a double tech crew and you pick up a crew sepsis, you're fairly certain it's red flag sepsis. Control tell you, I don't know, you're 10 minutes from Stoke Mandeville A&E, but you've got a paramedic 15 minutes away. Do you wait for the paramedic or do you go to Stoke Mandeville? You go to Stoke Mandeville. Probably the only time anyone will ever say that. So, Paediatric Management, very, very similar, but I'm less inclined to give fluid to kids. A, because actually they're buggers to cannulate, aren't they? If you can try and get a line into a child that doesn't feel well, good luck. It can be a bit of a nightmare. So oxygen, again, if their sats are low, measuring lactate if available, and 20 ml per kilo boluses of sodium chloride repeating if they're hypotensive. Children that are hypotensive are very unwell. So let's have a little look. What do we got? I've got some questions coming in, some good ones. Okay. Do we IO? So depending on the ambulance guidelines, so IO for conscious patients requires local anaesthetic. Not all ambulance services will allow that. Some do, some don't. Generally speaking, though, no, we don't IO conscious patients. So we just try and get a line in. normally you can. So with kids, generally no, that's pretty cruel to put an IO into a conscious child. Again, local anaesthetic, yes, aside, but still that's not going to be a pleasant experience for them. For sepsis, no, I wouldn't. And Irish guidelines, paramedic level, if septic shock suspected and not responsive to IV fluids, consider adrenaline. Fine, okay. That's so in the GLCAL guidance, that's not been a thing. So interesting to see the evidence behind that. So painless. Well, the IO. Well, supposedly the IO actually going in is painless, but believe me, the breakdown of the bone marrow isn't. So yes, you manage to get pain responses from seemingly the most unresponsive patients when you start flushing. Having not that long ago done it to a very unconscious DKA patient and flushing fluid, and suddenly they had a pain response. So the drilling might not be the most painful bit, but that is. So anyway, sticking to kids, 100% oxygen, and because GLCAL guidelines is what we follow, isn't it? Measuring the lactate if it's available as and when that comes out. Fluid if the paramedic's there, but we're not going to delay. We're going to go to A&E and hand over the presence of red flag sepsis. Good. So I've got a case study for you. And this is going to be the start of the quiz. So there's going to be 6 questions this evening in tonight's quiz. The way it works is the the quickest person to answer correctly wins the most points for each question. That accumulates, and the person with the most points at the end will win the 10% off voucher for any course of their choosing. So write down the observations. This is a patient, you've gone to an adult patient, okay, with a respiratory rate of 25. Thank you, Matt, put it in the chat for us. Stats of 92, room air, heart rate is 118 and regular. Blood pressure is 118/65. The blood glucose is 6.4, temperature 39.3, GCS is 14. And of course, we are suspecting sepsis, aren't we? This is what tonight is all about. Okay, so the observations are in the chat. I'm going to flick over to our quiz then. I would like, so what I'll say, before you join this quiz, if you haven't already, make sure you use your real name so I can tally you up at the end, okay? And you'll get 10% off any course of your choosing. So as many people can join as possible. So what have we got? Nearly 30 of you, so let's see if we can get 20 of you in the quiz. Once the quiz starts, you can't join. So if you want to join, grab your smartphone, menti.com 8983 3818 for a chance to win 10% off any course. See if we can get you up to 20. 6 questions tonight. Okay, fab. Right, we're going to get going then. So 6 questions to come. There you go. Have a look at your phones. First question coming up. What is this patient's News 2 score? 30 seconds to answer. I should point out this is your News 2 score before you give oxygen. So it doesn't mention oxygen. Let's see how everyone went there. A bit of a mixed bag there. So it was 12. Okay. Respiratory rate of 25 scores you 3. Saturations of 92% scores you 2. We haven't mentioned oxygen, so we assume the patient's not on oxygen at this point. Heart rate of 118 scores you 2. Blood pressure of 118/65 scores 0. Temperature 39.3 scores 2. And a GCS of 14 scores 3. So GCS of 12 in total there. Sorry, GCS of 12. News 2 of 12. Fantastic. Okay. Well done to 4 of you. Let's see who won. Okay, so Matt is in the lead. And I know which course Matt's going to use his 10% off if he gets it. So well done, Matt. Okay. Question 2, look at your phones, answer quickly. According to GeoCalc, how much oxygen should be given? Nice, easy one. Good, okay. Well done. So most of you getting that right. So 100% oxygen. So GeoCalc say if you suspect sepsis, it's in the red box, page 604 of the full guidelines. You do need to give 100% oxygen, and that's indiscriminate whether they have COPD or not. Okay, so well done to 14 of you that got that right. So let's see who got that quickest out of all of you. Going to be some quick scores there, isn't there? Okay, well done. So Liam just sneaking the lead there. Perfect. Okie dokie. All right, next question. Get your phones ready. Number 3 of 6. True or false? Paracetamol should be given for temperatures over 39 degrees. True or false? Okay, so not everyone answered there. Okay, well done. Most of you getting that right. So if you look at GeoCalc guidance, and actually if you look at NICE guidance, so paracetamol shouldn't be used when the desired effect is just to reduce temperature, because actually it slows the immune response. Paracetamol should only be given for the associated discomfort. So just because the temperature is over 39 doesn't indicate the use of paracetamol. So that's the same adults or children. We don't routinely give it for fever. So let's see who got that right. Okay. Perfect. Well done. So Liam still in the lead, Gohart right behind, and Stephen not far off. So Matt, how did you get that wrong? Honestly, I taught you nothing. So next question. Okie dokie, nice and quick. Which is the priority when dealing with sepsis? Rapid transport, giving oxygen, giving fluids, or giving antibiotics. What is the most important thing for the patient? Okay, good. Most important thing, according to the Sepsis Trust, which is what most trusts work by, is that we should be getting this patient to A&E, handing over the presence of sepsis, rather than giving any of the pre-hospital care bundles. So if you don't have oxygen with you, it's not a reason to delay. Take them to hospital. So let's see who got that right. Perfect. Okay. Well done, Matt. I think you've stolen your lead back there. No, not quite. Not quite. Okay. Stephen doing very, very well. Stephen Sheehan. Perfect. Okie dokie. Next question, please. Question 5 of 6. You suspect meningitis is the cause of sepsis. What additional drug can be given by paramedics? Comoxiclav, doxycycline, IV paracetamol, or benzylpenicillin. It's a little bit of a teaser there for any of you that have done some CPD. Which drug do paramedics give for meningitis? Okay. Boom, well done. So comoxiclav is generally, anyway, the drug of choice for sepsis in general. It's a good broad spectrum antibiotic that works both aerobic and anaerobic bacteria. And of course, yes, absolutely well spotted. Yeah, so bacterial meningitis, of course. So if you're suspecting meningitis, we give a drug called benzylpenicillin, and that's a relatively good one for tackling the meningococcal causes, typically of bacterial meningitis. Comoxiclav, yes, for sepsis in general, is generally the first line. Of course, both of these drugs are penicillin based, so cannot be used in penicillin allergic patients. So of course, there are other options. Such as doxycycline, but benzylpenicillin is the drug of choice for suspected meningism. Who got that right? Okay, who have we got there? So Matt just back up into third. Matt, Liam, and Stephen. It's all to play for as we go into the last question. So question 6. Look at your screens. Which type of shock is caused by sepsis? Cardiogenic, distributive, neurogenic, or hypovolemic? Boom, well done. So cardiogenic shock is generally caused by heart failure or acute MI. Distributive shock is where blood vessels are leaky. So sepsis causes distributive shock, as does anaphylaxis. Neurogenic shock is generally from high-level C-spine or spinal cord injury. And hypovolemic shock is more to do with rupture and damage to the arteries, so either external or internal hemorrhage. So distributive shock is, of course, the correct answer. Let's see who sealed the deal tonight then. So, Matt was quick there. It's going to be between Matt and Liam, isn't it? Liam, well done. He only just sneaked that, so well done. That was very, very close between the three of you. So, oh, Stephen, that's okay. You did very, very well. So, Liam, well done. What I'll ask is either you just drop me a message and either to webinars at STC, or you can ping us a message on the chat. Just with your email address, and if you've got a course in mind you want to book, let me know, we'll get you on. So very well done. Thanks everyone for coming along. Let's go back to the main slide. Very well done to Liam there. For winning. I hope people are finding those quite good. We've been looking at the feedback after the webinars. I think people are quite enjoying those quizzes, so we'll keep them in. They're here to stay. So that's sepsis. Hopefully that's been a good refresher for you. Hopefully you've enjoyed it. Oh, fab, thank you. Charlotte's in the chat. I was just about to copy that in. So Charlotte's just put links to leave reviews, and she's also put a link in there for your free certificate. So if you want to claim a certificate, just click on that link there. It will appear on our website and on Facebook later in the week as well. So if you do miss it, but it is in the chat. Scroll up a little bit if you need it. We do appreciate it if you leave us reviews. It does help us bring patients into our courses. And of course, we would love to see you all on a face-to-face course in the future. So do bear us in mind if you're looking at doing any of the FREC courses. We're back next week for another free webinar on oxygen and Entonox guidelines. That's next Wednesday, the 27th, again at 7:30. That will be a slightly shorter session. There's not a huge amount to know about those drugs, but of course we'll go through them. Thank you, Liam. I've got your email address. That's brilliant. I'll drop you a message over. Just have a look at our schedule if there's anything you want to do. We look forward to seeing you. But otherwise, folks, if you want to go, now's the time. You're not going to miss anything. There's the links again. Please do leave us a review if you've enjoyed tonight, and do claim your free certificate, which will be on our website and Facebook later in the week as well if you do miss it. And we hope to see you next week. Any questions I'll take from the audience? Just stop the recording.